So واضحة الشاشة عندكم؟
اي واضحة يا دكتور.
اوكي. طيب. بسم الله الرحمن الرحيم. Today we have two lectures. So first is the coronary artery disease or ischemic heart disease, and the second one is heart failure and cardiomyopathy. So today I will start with coronary artery disease. So we'll just touch base on definition, cause, symptoms, diagnosis, assessment, and care after discharge. So as you know, the cardiovascular disease is the leading cause of death and has been for the last 90 years. So it is number one death. So this is why it is important to know every single detail in ischemic heart disease. You have to read from the textbook. Question will be from my talk. It's not from slides, and it will be from the book. So I will just give you a guidance, and then you have to read about that. The incidence mortality declined in the last 30 years with the advent of CCU, fibrinolytic therapy, catheter-based reperfusion, and lipid-modifying therapy. However, the aging of population and the global increase of diabetes and obesity will increase the burden of atherosclerotic disease in the future. So in ischemic heart disease, I will just concentrate more on ACS, which is the acute coronary syndrome. Acute coronary syndrome has three categories: unstable angina, non-STEMI, and STEMI. As you can see here in this slide, you can see the burden of STEMI and non-STEMI on the hospital admission. So we have like 1.5 million hospital admission with acute coronary syndrome per year. So ACS is defined as a myocardial ischemia due to myocardial infarction, non-STEMI or STEMI, or unstable angina. In unstable angina, there will be no cardiac or myocardial necrosis, but the patient will have either angina at rest, new onset exertional angina less than 2 months, or recent acceleration of angina less than 2 months, or post-revascularization angina either after percutaneous coronary intervention or cardiac bypass surgery. So the spectrum of ACS, the patient might come directly with STEMI or non-STEMI or unstable angina. Some patient, they might progress from unstable angina, then he will progress to non-STEMI, and sometime in the hospital, he might get STEMI. So this is the spectrum of ischemia in those patients. If there is any question, you can stop me at any time. Okay. The pathophysiology of ACS and angina, when there is a mismatch between oxygen supply and demand, when that happens, the patient will develop chest pain or angina. So angina or chest pain will develop either if there is a flow-limiting stenosis. Sometimes it won't be only the flow-limiting stenosis. Sometimes anemia can cause chest pain, dyspnea, dizziness, or fatigue. And when there is a plaque rupture or clot, the patient might have non-STEMI or STEMI. When there is a necrosis, the patient will have either non-ST elevation MI or ST elevation myocardial infarction. Here, just to see the evolution of coronary thrombosis, how it happened. So this is the coronary artery of the patient. Here you can see there is some plaque, and there is some thin fibrous cap above that plaque. When there is plaque rupture, the coagulation system will be activated, and then thrombus will attach to that plaque, because this is not normal for the human being. Okay. When that thrombus occlude the coronary artery completely, so the patient will have ST elevation MI, because the patient will have complete occlusion of coronary artery. If that thrombus doesn't occlude the artery, if it's occluding like 80%, 90%, the patient might have either unstable angina or non-STEMI. Okay, so this is how you will get between STEMI, non-STEMI, and unstable angina in the pathophysiology. So this is just a recap for what I just explained. When there is a plaque rupture, there will be thrombus formation, and then it will be either occlusive or non-occlusive. Sometime this is the most common pathophysiology of acute coronary syndrome. Some patients, they won't have this one. You might have some vasospasm. We can see it in congenital angina, female patient, smoker. They might get occlusion of the artery, not due to plaque rupture and thrombus formation. Some patient might have progression of their obstructive coronary atherosclerosis, like this one. The plaque, it will propagate, but it won't rupture, and that will block the artery here. So the progression of atherosclerotic disease. And some patient, when they have some intervention like percutaneous coronary intervention, they might have in-stent thrombosis or restenosis. And sometimes there is some surgical technique related ACS post cardiac bypass surgery. How to diagnose ACS or ischemic heart disease? So it is very simple. So focused history, physical exam, there is nothing too much in the physical exam. ECG, either ST elevation or ST depression. Sometimes the patient might come with normal ECG and the cardiac enzymes. Then patient can be divided into several after we excluded the cardiac cause. They might have non-cardiac chest pain. We have gastrointestinal, musculoskeletal, pulmonary. Patient might have some stable angina or other cardiac cause like aortic dissection or pericarditis. Is that clear, or any question? Okay. So to diagnose ACS, we have to have at least two of the following: history of chest pain or angina, ECG changes, and typical rise of cardiac markers or enzymes, and absence of another identifiable etiology. So if the patient came with chest pain and he had pneumothorax, so this is less likely this patient will have ACS. So we have another identifiable etiology for that chest pain. Okay, so I think who's the leader? Who's the leader of this group?
عبد الله الحبيش.
وين عبد الله؟
سامي دكتور موجود.
اوكي عبد الله ممكن بس تحط لي اللي حاضرين الان وترسل لي اياهم، لانه at least third of the group is not attending the lecture. بس ممكن ترسل لأن أنا عندي 48، ممكن تسوي كابتشر سكرين للأسماء وترسل لي إياهم.
طيب تمام مو مشكلة. الشباب اللي ما سجل اسمه بالإنجليزي لا تسجل الحين، غير اسمه عشان يكون واضح للكل.
وأنا عندي 48 participant، أوكي 47 لأن أنا معاكم 48.
عبد الله معليش، بس يعني الحين اللي اسمه بالعربي خليه انجليزي.
كل واحد اسمه ورقمه، اسمه رقمه الجامعي، عربي ولا انجليزي ما يهم. Okay. So just how to differentiate between the SAS group. So how to differentiate between unstable angina, non-STEMI, or STEMI, or how you will call it, STEMI or non-STEMI. So this session will be more of interactive. Walid.
Yes, دكتور نعم.
Okay. So how you will differentiate between STEMI and non-STEMI?
اشوف اس تي سيجمنت دكتور اذا كان مرتفع او لا. الاستمي يعني السي سيجمنت will be elevated but non-STEMI ما راح يكون في elevation للسي سيجمنت تكون depressed.
Okay. And how you will differentiate between unstable angina and non-STEMI?
ما اعرف دكتور.
Any other thought?
history and physical.
Okay, أسامة الحربي. Yes, أسامة.
دكتور معلش. أيوه يا دكتور.
How you will differentiate between unstable angina and non-STEMI or non-ST elevation MI?
الصراحة ما أعرف.
Okay. عبد العزيز اليوسف. Okay. عبد العزيز اليوسف شكله مو معنا، ف this is absent. عبد العزيز اليوسف. عبد العزيز القثامي. الخثعمي.
سلام دكتور، صراحة ما عندي معلومة كيف الفرق بينهم.
تكلم يا دكتور.
What happened to the meeting?
ما ادري قطع الصوت فجأة.
قطع الصوت فجأة يا دكتور. ما
في السكرين شير فيه ولا لا؟
لا راح في السكرين شير.
اوكي. Okay, Abdulaziz and Nail. Okay. عبد الله
سمي دكتور.
اي واحد انادي عليه ما يرد تحطه غايب بعد. اوكي، الان عندنا 3 لحد الان ناديت عليهم ما يردون.
طيب تمام.
اوكي، وارسل لي الاسماء بعد ما هذا بعدين نشوف ايش المشكله اللي صايره معكم. Because this is not ideal for me to prepare lecture to be on time, and I can see only less than 2/3 of the student attending the lecture, so that's not appropriate for me.
دكتور النايل رد في الشات يقول لك انه ما يقدر يفتح المايك.
اوكي،
وما عنده مايك.
يعني الشيء هذا عارفينه كلنا. كيف يعني ما في مايك؟ يقدر يتكلم بدون مايك؟ يعني ايفون يتكلم يعني I don't know يعني كيف ما يقدر يتكلم بدون مايك على الكمبيوتر؟ طيب انا بعد على كمبيوتر الحين شغال، يعني كيف يعني ما اعرف، يعني it doesn't come on my head.
دكتور اذا كان بي سي
انا شغال الان
اذا كان بي سي كمبيوتر مكتبي يحتاج يكون عنده مايك، لكن اذا كان لابتوب عادي بدون مايك. فممكن عزيز عنده بي سي، ما ادري والله عنه.
اوكي. Okay, so that's very annoying for me. I think online lecture is not an appropriate things because I thought it is on site. I just know today it is online. I think no need for any online teaching now, because everything now is open. There is no distancing. I think you should come to the clinic, to the college for that. I will just check with Dr. Ryan, because this is not fair and shouldn't be so, because there is no distance now, so you can just sit together and you have one hall.
اي صحيح دكتور، مو مشكله انه في ديستنسنج، المشكله انه زي ما انت عارف الدوام في تسمعني دكتور؟
تخلصون الساعه 12 تجون الكليه عادي. كنا يعني انا كنت اداوم في
دكتور بالسويدي، نداوم بعضنا ساكن
بالسويدي، والطريق يوقف. احنا اذا نداوم بالعليه يوقف علينا، المشوار ياخذ اكثر من 40 دقيقه احيانا، فما بالك اللي بالسويدي واللي بالريان واللي بالدرعيه. فمره الموضوع صعب.
بس الحضور هذا ما هو كويس يا عبد الله. انت واللي معك اللي قاعد تتكلم.
صحيح والله
يعني عددكم 75 وهذا بيجوني 45 والنص الان لو اقعد انادي ما حد معي.
دكتور ترى عددنا اقل من 70، عددنا في 69 اظن.
69 يعني 70 يعني نفسها يعني 1/3 not attending this lecture. Okay. Okay, so continue that. So unstable angina when there is no occlusive thrombus, no specific ECG changes, normal cardiac enzyme. Non-STEMI when there is non-occlusive also, but you might see some ECG changes on the either ST depression or T-wave inversion, and you will see elevated cardiac enzyme, and this is how to differentiate between unstable angina and non-STEMI. ST elevation MI, the same as non-STEMI, but you will see ST elevation on ECG, and the patient will have more severe symptoms.
دكتور
This is, yes.
في سؤال عن difference between STEMI and non-STEMI. هل نقدر نقول انه non-STEMI يكون الانجينا معها ما يكون في معها انجينا او الانجينا معها ما تكون unstable والستيمي تكون unstable انجينا؟
ما فهمت سؤالك.
انه هل نقدر نقول انه والله patient جاء he have chest pain but it's stable, we could think about non-STEMI. إذا كان unstable we could think about STEMI.
No, the STEMI won't be stable. He will have severe chest pain, and you have to do the unstable angina. Once the patient came to the emergency room, if you think about unstable angina, he will come with chest pain, or they will come with chest pain. If he come with chest pain, you will look to his ECG. The first thing you will do. If the ECG doesn't show any changes, either ST elevation or ST depression, so if there is no ST elevation, so this is not STEMI, okay, and then you will order the cardiac enzyme. If the cardiac enzyme came back positive, this is non-STEMI. If the cardiac enzyme is negative, this is unstable angina because of the symptoms. This is how to differentiate between them.
Clear.
Okay, so the initial evaluation and management of non-ST elevation MI. So as I said, the history, some physical exam, focused history physical exam. Then if there is a chest pain, ECG should be done within 10 minutes of the patient arrival to the emergency room, and then cardiac biomarker. If there is no ST elevation, you will go with the cardiac biomarkers. This is how the anginal pain or the chest pain, so chest pain radiating to both arm or the left arm, sometimes to the jaw. There is some difference, especially in female and elderly people. Those people will come with chest pain, or sometimes they will come with dyspnea and palpitation. They will have different presentation to the emergency room. So the likelihood of SAS by history and physical exam. So once the patient has chest pain or pain radiating to the left arm, the likelihood ratio of this patient having SAS is 2.7. That likelihood ratio will increase when that pain radiating to the right shoulder, left arm, or both left and right arm. Those patients also will come with diaphoresis. In physical exam, you might hear third heart sound. If the patient has systolic blood pressure less than 80 millimeter mercury, the patient will have cardiogenic shock. That's also, it will indicate this patient will have a likelihood ratio or likelihood SCS. And if the patient had pulmonary crackles, the patient went into heart failure, the patient will most likely have SCS, precipitating his heart failure. So risk stratification by ECG. So ECG, as we know, it is a simple, quick, and non-invasive tool. Can be done in ER or in the ward, in any hospital place. It is universally available and cheap. It is correlating with the risk and prognosis, and it guides your treatment decision. Because if the patient has ST elevation MI, the patient will go directly to the cath lab. But if this non-STEMI or unstable angina, you will wait and then you will decide. And ECG also can identify alternative causes for chest pain. So not every ECG or not every abnormal ECG will include or exclude ACS, but sometimes you can see a patient with ACS presenting with normal ECG. So you can see here the likelihood ratio increased when there is ST elevation in MI more than 1 millimeter. So 1 to 8% of patients with acute myocardial infarction, especially non-ST elevation, because in ST you will see ST elevation. Non-ST you will see those patients having a normal ECG, and only approximately 50% of acute myocardial infarction patients have diagnostic changes on their initial ECG. So here, how sensitive is the ECG alone? As I said, 10 to 20%, the patient will have normal ECG. If there is ST depression, the likelihood ratio will be 50%. If there is ST elevation, 60%, because there is another differential diagnosis of ST elevation MI with or ST elevation in the ECG, like pericarditis, early repolarization syndrome, some congenital heart disease called Brugada, so you can see ST elevation MI. If there is a Q wave in the ECG, the likelihood ratio will increase up to 70%. If there is ST elevation with some reciprocal changes, the likelihood ratio will be 90%. And if there is ST elevation with reciprocal changes and Q wave, the likelihood ratio of MI will be 90 to 95%. So this is an ECG of one of the patients who presented to the emergency room with chest pain. Abdurrahman al-Muhayya.
سمع دكتور.
Okay, I think you took the ECG lectures, isn't it?
اي دكتور خدناها.
ايوه جدد.
Okay, so what did you see here?
Elevation.
What is the elevation? You have to be very specific. What is the elevation?
On the right side.
Well, what is the right side? There is nothing in the ECG called right side or left side. Either V2 or V1 or what? Lead 1 or lead 2?
V4. V5 and V6.
Okay. Ahmed al-Turki.
موجود دكتور.
Okay. What did you see here at the ECG? أنس الرشيد.
موجود دكتور بس ما أعرف.
Well, what did you see?
elevation V4 V5.
Okay. Badr al-Said.
Sunday.
What did you see here in the ECG?
والله يا دكتور ماني متأكد.
Okay, who want to volunteer for this ECG?
ST segment elevation and V3 and V4.
Who's this? Rakan, في Rakan.
Abdullah,
Okay,
this is Abdullah.
Okay, Rakan.
اتفق مع عبد الله V3 ST elevation بس ما ادري عن V4.
V3, yeah. But this is the isoelectric line and this is the isoelectric line. There's no did you see my mouse, the mouse?
واضح يا دكتور شوف.
This is the isoelectric line and this is the isoelectric line, so there is no ST elevation.
معناته نورمال اعتقد.
Okay, this is normal ECG. Okay. So this is a normal ECG. So for any ECG, don't just jump to the finding. So how to read ECG? First, you have to have. So is this the same patient? So just say this is an ECG for XY or XX. His file number is 1, 2, 3, and 4. This is a regular rhythm, sinus rhythm, and you will calculate the rate, and then you will see the PR interval if there is any AV block, and then you will comment about QRS complex if it's wide or narrow, and then you will comment about the ST segment elevation. The ST segment, is it depressed, elevated, or normal? And then you will comment about QT interval, is it prolonged or is it short? This is how to read the ECG. If you jumped, even the prof of cardiology, if he jumped to the finding, he will miss a lot of things. So this is the ideal interpretation of the ECG. Okay, so the timing of release of biomarker after acute MI. This is why we don't wait the cardiac biomarker in ST elevation MI, because as you can see here, the troponin will be high after like 6 to 8 hours. So you can't wait for 6 to 8 hours to see how is the troponin. And you can see here the maximum of the troponin will be at 2 to 3 days, and then the troponin will decline over 1 or 2 weeks. CKMB also will be elevated with troponin at the same time, 6 hours, and the maximum will be at around 24 hours, and then it will start to decline. So the CKMB is a good cardiac biomarker for in-hospital re-infarction, because the troponin will be still high, but the CKMB, if the patient develops chest pain here at the second day, you will order the CKMB, because if that is still rising, that will it will give us that the patient have a re-infarction. So you won't rely on the troponin, because troponin is still high. The first cardiac biomarker will be released is the myoglobin, but it's not specific for the MI, but we still, some people, they are using it. So the risk stratification by troponin, the more the troponin, the higher the mortality at 42 days. You can see here the troponin of more than 9, the mortality will reach 7.5% at 42 days. Not every troponin is because of the heart, because you will receive a lot of calls from the emergency room or from the other department. This patient has high troponin. There is a list of different causes of high troponin: trauma, congestive heart failure, any valve disease, hypertension, especially hypertensive emergency or urgency, any sometime procedure or surgery, renal failure, hypothyroidism, sepsis, burn, rhabdomyolysis, transplant vasculopathy. Here is the algorithm how to treat the patient with ACS. So we have initial treatment of ACS for all STEMI, non-STEMI, and unstable angina. So we'll have the antiplatelet, anti-ischemic, or anticoagulant therapy for all. If there is ST elevation MI on the ECG, either the patient will go to thrombolytic therapy or PCI or CABG. So if the patient presented to a non-PCI center, he will receive thrombolytic therapy. If the patient presented to the PCI center, he will have a PCI most likely. if the patient doesn't have STEMI, if he has only or either non-STEMI or unstable angina, so there is early invasive therapy, like in 24 to 48 hours, either PCI or the patient might have CABG, or some elderly people, they are not for any surgical intervention, you will just go with conservative management. And then after that, you will go for the long-term medical management for those patients, like antiplatelet therapy, anti-ischemic, statin, and hypertension or diabetes management. So early hospital care, antiplatelet, anti-ischemic, and anticoagulant therapy for all of the STEMI, non-STEMI, and unstable angina. So for the anti-ischemic, class 1, bed rest, oxygen if the oxygen less than 94, but if the oxygen more than 94, no need for oxygen. Nitrate, either sublingual, topical, IV, or oral tablet. Beta blocker, non-dihydropyridine calcium channel blocker, if there is a contraindication for beta blocker, and ACE inhibitor in the first 24 hours, and statin. This is the anti-ischemic, and we'll come to the antiplatelet, also class 1. So the aspirin, you will just load the patient with 300 milligram aspirin, and then you will give them also oral platelet P2Y12 receptor antagonist, like clopidogrel, ticagrelor, or prasugrel. And then you might consider glycoprotein 2B3A inhibitor, and it is based on whether you will go with invasive or conservative management. Glycoprotein 2B3A inhibitor always recommended, or sometime better to be given in patient diabetic and early invasive management. Anticoagulant, unfractionated heparin or low molecular weight heparin. If there is a contraindication for that, you might use bivalirudin or fondaparinux. Also depends on invasive and conservative management and bleeding risk for the patient. So STEMI, the treatment of choice is reperfusion, either by percutaneous coronary intervention or PCI, if the patient present to a PCI capable facility or center, and fibrinolysis if the patient presented to non-PCI center. You can see here this is a systematic overview, difference between PCI versus fibrinolysis in ST elevation MI. You can see here the PCI is better than lysis in death, shock, reinfarction, recurrent ischemia, and stroke. So the medical therapy for STEMI, as I said, anti-ischemic, anti-platelet, and anticoagulant, so aspirin and P2Y12 inhibitor, anticoagulant, either unfractionated heparin or low molecular weight heparin, glycoprotein 2B3A if it's in the invasive arm, beta blocker, and statin. You can see here the importance of rapid reperfusion in ST elevation MI, because this is why we don't have to wait for the troponin for STEMI patient, because you can see the mortality will increase, and for every 30 minutes the mortality will increase 8% in 1 year. Okay, so this is an ECG. Any volunteer for this ECG? Okay, so because this is only additional points for you, because I didn't see any attention from your side, and so I'll just go as you want or as you like. So this is ST elevation in lead 2, lead 3, and AVF. So this is inferior myocardial infarction with some reciprocal changes in V5 and V6. This is how to put the stent in a patient with either STEMI or non-STEMI. And this is the, yes.
وش بالستيمي نستمي يعني فيها ليد من الليدات نركز عليها أكثر من غيرها؟
I think all you took the lectures for that. I think it is long. It's 4-hour ECG lectures. So there is inferior. There is So there is inferior. There is anterior, lateral. So inferior is lead 2, lead 3, AVF. This is the inferior. Lateral will be lead 1 and AVL. And anterior will be V1, V2, V3, V4. That's the anterior or anteroseptal. And if it's including the V5, V6, we'll call it anterolateral. This is how to read the ECG, or how to know if it's inferior, anterior, or lateral. So this is the right coronary artery. You can see, because it is inferior MI, the most likely artery involved in that patient is right coronary artery. You can see here there is complete occlusion of right coronary artery, and this is after intervention. So you can see the flow of the artery. So the unstable angina non-STEMI, you will just go for either invasive or conservative management based on the age of the patient and any risk factors or high risk features, we call it. If the patient is hypotensive, or we will prepare invasive strategy. If the patient has any arrhythmia like ventricular tachycardia, we'll just get the patient directly to the invasive management. Sometimes some patients will start with conservative, and then we'll take them to the cath lab once they are stable. There is 2 scores called TIMI risk score and GRACE score. I usually use GRACE score, which is a score used to risk stratify patients and to stratify them and to get some mortality score for them. So I use GRACE score, so sometimes it will be beneficial for patients with non-STEMI or unstable angina. And then you will stratify them as low, intermediate, or high risk based on their score. So this is the TIMI risk score. It is an old score. Still people that are using it. It is a point, so you will just sum up these points, and then so if the patient age more than 60 and has 3 cardiac risk factor, so he will have 2 points. The mortality will be 10% within 14 days, so, and the mortality will increase with more points. So this is risk, the TIMI risk score, and also we have GRACE score that include more points like creatinine and the age of the patient. So if you think about ACS, you have to initiate medication as soon as possible. You will start the antiplatelet, anti-ischemic, and anticoagulant. Patient might go either to coronary care unit or cardiac telemetry. If you decide about early invasive strategy, if there's a positive biomarker, mu ST segment deviation, either ST elevation or depression, you will take them to the cath lab. And if the TIMI risk score more than 3. Conservative management, if it's negative biomarker, no ST segment deviation, TIMI risk score of less than 3, especially women, you will just go with some conservative management. early invasive management. It is a 24-hour, or we'll do the angiogram in within 24 hours. But those patients on the conservative arm, we will check the echo, we'll check some exercise testing. If it's positive, we might go for invasive management. So in summary, acute coronary syndrome include unstable angina, non-STEMI, and STEMI. Management guideline focus on immediate assessment. It is very important on this word, immediate assessment and intervention, because every minute delay in assessment or intervention in those patients will result in either death or heart failure. Then you have to risk stratify those patients either by TIMI risk score or GRACE score, which I prefer, and rapid reperfusion for STEMI patient, either PCI or thrombolysis, and conservative versus invasive management for unstable angina versus non-STEMI. So we have some ECG. Any volunteer here?
I think there is ST depression in 2, 3, and AVF.
Okay.
And also in V5 and V6. And there is ST elevation in 1, 2, 3, and 4.
Okay, so as I said, we should go systematic for any ECG. This is the patient, because you might get wrong ECG for another patient and you will decide about other patient, which might happen. So this ECG for X or Y, the file number is 1, 2, 3, 4, or 5. You can see there is a P wave. So this is a sinus rhythm. The rate is, you have to calculate the rate, and then you will look for the PR interval. I couldn't see any PR prolongation or PR or short PR, and then you will see the QRS complex, and then you will come to the ST segment. So you can see very obvious here ST elevation in V1, V2, V3, and V4. With some reciprocal changes. We call it reciprocal changes or ST depression. We call it reciprocal changes in inferior lateral leads. This is the inferior, lead 2, lead 3, AVF, and V5, V6 is the lateral leads. So this is, and then you will conclude. So this is, this ECG showed ST elevation in anterior leads with reciprocal changes in the inferior lateral leads. This is how to read the ECG. And you can see here the coronary angiogram, which showed complete occlusion of left anterior descending artery, because it is anterior ST elevation MI, and this is after stenting the artery. Here, any volunteer?
First, I will check for the patient's data. Then I will check for the sinus rhythm, which is present.
Okay, there is a P wave, so it is sinus.
Then I will calculate the rate, which I think is 75, which is normal. The PR is normal. The QRS as well. There is ST elevation in lead 2, 3, and AVF.
Okay, excellent.
And ST elevation in 2, 3, and 4, and 5.
And 6.
And 6.
Okay.
I think it's. I think it's normal QT interval, and I think it's anterior inferior MI.
Okay, so this is inferior lateral MI, or okay, and you can see here some reciprocal changes. Okay, excellent. So this is, we call it inferior lateral. If the right coronary artery is dominant, so you might see that ECG changes. Okay, this ECG. Any volunteer? This is not exam. This is a lecture. So if you don't ask, or if you don't participate, yeah, if you don't participate, you won't get any knowledge, because I can't give you all knowledge.
هذه نون ستيمي دكتور.
There is nothing called in the ECG STEMI or non-STEMI. ECG, you will just mention, you will just mention either you will just go with systemic, and then at the conclusion you will say only there is ST depression or there is ST elevation, but you can't diagnose, because even in the ST elevation you might see some ST elevation in non-MI patient. There is a lot of cause of ST elevation in ECG, so you won't call it ST elevation MI.
طيب هذه on lead 1 and 2 there's depression, ST depression. Also on V2, V3 there is depression.
Okay, so as I said, systemic first, rhythm, rate, also the axis. Also, I forgot it. You have to get the axis. Is it normal axis, left axis, or right axis? You'll look for lead 1 and ABL. So this is normal axis, and then you'll check the rate. You'll check the P wave. You can see P wave here. So this is sinus. And then you will look for the QRS complex. It is normal QRS complex because it's between 3 and 5 small square. And then you will check the ST segment, so you can see. So you will go to the either anterior, inferior, or lateral. So in the lateral, you can see some ST depression, as you said, lead 1 ABL. There is some ST depression. Inferior, I can't see any depression because it is the same. It is the same isoelectric line, so it is not ST elevation, because you can see here. This is the isoelectric line. This is the isoelectric line, so it is not elevated. And then V1, it is I will call it normal. But here in V2, V3, V4, and V5, there is some ST depression. Because see the isoelectric line, the isoelectric line is not the same. So here is the isoelectric line, and here is the ST. So there is ST depression in V2, V3, V4, and V5. So this is, you will just call it. So this is the ECG of X. His file number is 1 or 2. Patient has the sinus rhythm, rate of 80. Patient has ST depression in V2, V3, V4, and V5 with some lateral also ST depression. So this is how to interpret the ECG. So here this patient had ST depression, so this is most likely non-ST elevation MI. So you can see here there is some flow, but not complete occlusion, as I explained in the pathophysiology first in this lecture. Because you can see here there's some narrowing. It is like 90 or 95%. And here it is after stenting the coronary artery. So this is we call it the LAD, or left anterior descending artery. Okay, any question?
دكتور انا في الدياجنوز ما اقول يعني مثلا هذا ستيمي ولا نص سمي، اقول مثلا في ستي elevation وتبريشن صح فقط.
Yes, you can diagnose. All you can diagnose an ECG or chest X-ray or anything, CT brain. You can't diagnose. You'll just put your finding, because you have to have history, physical exam, ECG, cardiac enzymes, and then you have to diagnose. So this patient came with chest pain. ECG showed ST elevation, MI or ST elevation in anterior leads, the most likely diagnosis is ST elevation MI. You will say like this, but you can't diagnose on specific investigation.
دكتور بعد اذنك بسلايد 24 البايو ماركرز يعني نشيك على المايوجلوبولين ولا على
No, myoglobin, nobody is ordering it now. It's not specific, but it is the first enzyme will rise in patient with MI. It will rise in 2 to 4 hours.
فنشيك اللي هو CKMB.
Troponin is the most and is the most specific and sensitive to diagnose MI. CKMB, some people they are using it, but now troponin is the most specific one. But for the reinfarction, the CKMB is better.
Reinfarction يعني إنه جته أتاك ثانية قصدك؟
In the hospital, yes. After 2 or 3 days.
هذا نشوف CKMB.
Yeah, because troponin will be still high. So you can't rely on troponin. Okay, so now it is 2.
Doctor, I have a question, please.
Okay. What's your question?
The risk stratification for the STEMI, which is the GRACE score, we use it after the revascularization or when we specifically use it?
On admission. On admission, yes. On admission, you will calculate that score.
Before we proceed to the revascularization.
Yes, because you don't need the score for is it after or before. Because there is nothing like detail or data from the angiogram. You will need it to fill this score, because it is consist of age, heart failure, blood pressure, serum creatinine, but there is nothing in the. You need some data from the angiogram.
Doctor, I have a question.
Okay.
Regarding the first ECG you show in the lecture, V6 lead should be R wave, and V6 lead should be the highest R wave in normal condition. You mentioned it's normal, but R wave in V4 and 5 was higher.
Where? Yes.
أول ESG. تعديتها قبل شوي.
هذا؟
ايوه هذه. مو المفروض تكون الار ويف في الفي 6 ليد تكون هاير in normal condition I mean.
You mean where in which lead?
في 4 وفي 5 الار ويف مو higher than the R wave in V6.
I wouldn't. No. Not usually.
Because Dr. Muhammad mentioned it's normally propagation phenomena where
you will see in V6 more R wave. You mean?
No.
So you mean the R wave in V6 should be taller than R wave in V5 and 4?
Yes.
Or
Yes. This is what I mean.
Not always, because sometimes in the left ventricular hypertrophy, you will see those taller than the V6, but not always. So this is not criteria for LVH, because that's in the criteria of LVH. You will see V4 and there is some calculation for that. But this is not typical for left ventricular hypertrophy. So there is like 4 or 5 criteria to check the LVH in those patients, but not always. But sometime we might use it in the LVH patient to diagnose LVH on the ECG. Okay, any other question? Okay, so we'll have 5 minutes. So now it's 2:05. 2:10 we'll start the heart failure, okay?